everyone, my name is Llarena, and I'm a fellow in reproductive endocrinology and infertility at the Cleveland Clinic. Today I'm going to talk about the impact of endometriosis on embryo morphokinetics. I have nothing to disclose. So endometriosis occurs in about 10% of reproductive age women, and between 30 and 50% of these women struggle with fertility. There are a number of different mechanisms that contribute to infertility in endometriosis. Perhaps the most obvious is that in moderate to severe disease, you can get anatomic distortion that can affect ovum capture and fertilization. We know that women with endometriomas have decreased ovarian reserve at baseline, and surgery can further deplete that reserve. And endometriosis also creates an inflammatory environment in the peritoneal fluid, and that can reduce both sperm and tubal motility. And endometriosis also affects the endometrium, and women are thought to have decreased endometrial receptivity. But the issue that we're going to focus on today is impaired embryo quality. So data on this topic are mixed, but some studies suggest that women with endometriosis have decreased implantation rates and increased rates of arrested and abnormal embryo development. And this hypothesis is supported by studies of egg donation. Women with advanced endometriosis who receive embryos from healthy women have normal implantation and pregnancy rates, whereas women who are healthy who receive embryos from women with endometriosis have compromised implantation rates and embryo quality. Despite these challenges, IVF seems to overcome most of these issues and really optimizes fertility outcomes for women with endometriosis. Although women with endometriomas have a higher rate of cycle cancellation and a lower mean number of oocytes retrieved, this doesn't lead to a decrease in clinical pregnancy or live births. And overall, IVF outcomes are similar for women with and without endometriosis. So given the mixed data about embryo quality, is there a way that we can use technology to learn more about these embryos? And because of time-lapse microscopy, the answer is yes. Previously, embryologists would check on embryos in their incubators once a day, and so we didn't have detailed information on when exactly embryos were reaching developmental milestones. Maybe you get lucky and you happen to see an embryo during a key time point, but mostly you could tell when you looked at the embryo whether or not it had reached a particular stage at the time that you were looking at it. But with time-lapse microscopy, we get detailed information on exactly when embryos achieve key milestones, and so we can do detailed quantitative comparison of cell cycle events that might show subtle differences between embryos. So this is a video of an embryo reaching the blastocyst stage, which is when we typically do an embryo transfer. And this video happens to be from the company that makes the time-lapse microscopy system that we use, but it's a good representation of the ones that we see in our own lab. And there are a limited number of IVF programs that use time-lapse microscopy in their lab, so we're really lucky to have this available, and I'm excited to be able to show you some data. So here we did a retrospective cohort study with the goal of comparing embryo morphokinetics, that's the timing of various events in embryonic development, between embryos derived from women with and without endometriosis. We included patients under 39 who were diagnosed with endometriosis either by laparoscopy or by the presence of an endometrioma on imaging. And our control group consisted of patients who were doing IVF because of a prior tubal ligation, male factor infertility that didn't require surgical sperm extraction, uterine factor infertility, or patients who were doing IVF with a donor egg. And patients with PCOS, recurrent pregnancy loss, and unexplained infertility were excluded. And we excluded patients with PCOS and those requiring surgical sperm extraction because embryos in both of those scenarios have shown morphokinetic abnormalities. And unexplained infertility was excluded because we were concerned that there could be cases of undiagnosed endometriosis in that cohort. So first, let's look at IVF cycle outcomes. So the cohort without endometriosis is on the left, and the cohort with endometriosis is on the right. So overall, outcomes were similar for both groups. There were no differences in the ages of the patients or the average number of eggs retrieved. There was, however, a significant difference in fertilization rate. The endometriosis group had a fertilization rate of 56%, whereas the group without endometriosis had a fertilization rate of 76%. So that's a pretty large difference. Despite that, there were no differences in implantation, pregnancy, or live birth rates, and there was no difference in the rate of blastulation, or the proportion of embryos once fertilized that progressed to the blastocyst stage. So this table shows embryo morphokinetic parameters. Again, the cohort without endometriosis is on the left, and the cohort with endometriosis is on the right. And this compares the average number of hours at which embryos achieved key developmental milestones. And we don't see a difference here between the two groups. But where we do see a difference is here. So there are optimal timings for each developmental stage that have been published as we've started to learn more about embryo morphokinetics. So here what we're looking at is the percentage of embryos in each group that fall into these optimal time ranges that have been published. So the group without endometriosis is in blue, and the group with endometriosis is in red. So here TSB is the timing of the start of blastulation, and TEB is the timing of blastocyst expansion. And we'll talk about what that means in just a moment. But for now, notice that the endometriosis cohort in red has a smaller percentage of embryos falling into these optimal time frames. So what does this mean? The start of blastulation is an important marker of implantation potential and aneuploidy. This is a figure from a morphokinetics paper that was authored by one of our previous fellows, Linnea Goodman, showing that the timing of the start of blastulation is an independent predictor of implantation potential. This also fits with what we know about implantation from doing IVF. We know that embryos that have reached the blastocyst stage by day 5 after fertilization are more likely to implant than embryos that become blastocysts on day 6. Based on the results of morphokinetic studies, the timing of blastulation has also been proposed as a marker for aneuploidy. And finally, the timing of expanded blastocyst formation is also associated with implantation. And this fits with existing data showing that embryos derived from women with endometriosis have lower implantation rates. So we can conclude that embryos obtained from women with endometriosis are less likely to fall into optimal time ranges for two key developmental milestones that are associated with both implantation and aneuploidy. And although IVF cycle outcomes are similar for women with and without endometriosis, fertilization rates are significantly lower in women with endometriosis compared to controls. And some limitations of this study are the retrospective design and the small sample size, but data collection is ongoing and we expect that to increase substantially. And as our sample size increases, we also plan to do comparisons stratified by endometriosis stage. And before concluding, I'd just like to give a big thank you to Dr. Desai and Dr. Falcone for their guidance and support. And that concludes this presentation. Thank you for listening and for the opportunity to share this work.